We are going live in 3, 2, 1. We are live now.
After a minute, we start. Good evening, ladies and gentlemen. A warm welcome to all of you. This is episode 57 of much awaited Secrets of Neurology. It's been a knowledge feast for all neurologists across the world. And today, we would also like to warmly welcome our presenters from prestigious Narayana Medical College, Nellore, a very interesting case presentation titled A Perplexing Neurological Illness by Diagnosis, Evolution, and Outcome. And we assure you it's going to be extremely enriching. A warm welcome to our course director, sir. It's been purely your great determination and perseverance that this episode is about to complete year 5. We are in episode 57th. Both our program directors needs no introduction, Dr. Sudhir Shah sir and Lakshmi Narasimhan sir. Despite extremely busy schedule, you make it on the last week, Friday, every month, year on year. A warm welcome to Dr. Divya, Dr. Anusha, Dr. Ashrita, and Dr. Sampath Kumar. And they are the one who are going to enrich us. We all know that the secrets of neurology happens every last week, every Friday, and normally it consumes 1.5 hours of our time. Legendman Dr. Sudhir Shah sir needs no introduction. Sir has always guided us to be very brief in his introduction, but I can't stop without saying this, that sir is professor and HOD at prestigious NHL MMC and SBPI MSR Ahmedabad. Sir is also director of neuroscience at Sterling Hospital Ahmedabad. Many affiliations and accolades to Dr. Sudhir Shah sir's credit. Just to mention a few, conferred with most prestigious Padam Shri because of his immense work to society, contribution to research and development in the field of neurology. Sir has also been awarded Bharat Gaurav Award at Senate of France on 5th January 2024, which is one of the highest international award for Indians. Dr. Sudhir Shah sir is also recipient of BC Roy Award and has immense interest into the field of stroke, neurodegenerative disease, and epilepsy. Thank you, sir, for guiding us, mentoring us to reach us till the 5th year. Our second program director, we are extremely thankful to you as well, sir, Professor Dr. Lakshmi Narasimhan Ranganathan, sir. We know him very well, Director and Professor, Department of Neurology at prestigious Sri Ramchandra Institute of Higher Education and Research, Chennai. And he also went on to do and built Madras Medical College in his previous stint. Many awards and affiliations, Paltusi Advisor, A.B. Baker's Award, Best Paper Award at AN. But what I fondly remember is his contribution to so many students at large, including the secrets of neurology. Many of the DM and DNB students are extremely grateful to you, sir, for your mentorship. May I request both our program directors to introduce the panel, the participants from prestigious Narayana Medical College, Nellore, and take it forward from here, sir.
Hello. I just wanted to welcome you all for this wonderful Feast of Neurology, that is Secrets of Neurology. And it's a matter of immense pride for all of us that it is running so well, the 57 consecutive episode. one of the highest running webinar series for neurologists, where not only the students but also the seniors also participate and contribute. And I'm here to thank all, especially my co-course director, Dr. Lakshmi Narasimhan, and all the delegates, as well as all 56 institutes who have contributed the cases, including the resident doctors, assistant professors, associate professors, and the professors head, who have done wonderful, eloquent discussion of different cases. We are thankful to all of you for giving this much prestige to this wonderful concept of Secrets of Neurology webinar series. With that, I would request Dr. Lakshmi to take over. And before that, it's my duty to thank Mr. Chadda and his team at Celestial Intas, the Globusel marketers, for their immense logistics support all throughout all these webinar episodes. Dr. Lakshmi, may I request you to please take over?
Yes. Thank you, sir. Thank you so much, sir. So I have, and sir is the immense. His presence itself is immense value, and he has been a guiding force for all this, the neurological secrets. And I have the great pleasure in inviting Professor Sampath Kumar from Narayana Vidyalaya, which is my Narayana College from Nellore, and Dr. Divya. I saw her during the examination in Nellore, Senior Resident Department of Neurology, Narayana Medical College. She had done her MBBS from JSS and MD Medicine from Ashram. Right now doing DM Neurology final year at Narayana Medical College. May I have the next slide, please? And she is going to be, and the assistant professor, Dr. Anusha, from MBBS from Kurnool and MD General Medicine gold medalist from Venkateshwar Streams College in 2014, and DNB from Manipal, Bangalore, and received the gold medal, All India gold medal from DNB. And she's going to discuss the case. And final concluding remarks will be given by my close friend Sampath Kumar, Professor HOD, Department of Neurology, Narayana Medical College, senior neurologist with 23 years of clinical expertise, credited with 36 publications, editor for Neurology Index journals, contributed 3 chapters in neurology, life member in IAN, IAP, MDSI, NSI, FIMSA, FCIP, IMA, and AOPL, National Executive Board member for IAP Neurology Chapter, Executive member of APNSA, Coordinator of Board of Studies Super Specialty Dr. NTR University of Health Sciences, member of Academic Senate of Dr. NTR University of Health Sciences, Movement Disorders, Botox in the area of epilepsy, has been there a very active and popular teacher in the South. I welcome you, Dr. Sampath Kumar, and request you to take over the proceedings from now on. Thank you.
Sir, you're on mute. Dr. Sampath, you're on mute. Please unmute yourself.
Thank you.
Yeah.
So thank you, Dr. Sudhir Shah sir and Dr. Lakshman sir, who is so much encouraged to take part in this program. And thank you to the INTOS, Dr. Arun and Dr. Manoj, and all my team. I think this is a case, without wasting all my time, Divya will start the case with proceedings. Dr. Divya.
Sure. Sure. Good evening to one and all. I'm very privileged to be presenting on this platform today. Today, I'll be discussing an interesting case which we witnessed in our neurology OPD just a few months back. This is a case of 50-year-old male patient who is left-handed individual, who is a resident of Uppalapadu. He is a laborer and farmer by occupation. He came to our OPD with the primary complaints of history of pains in both lower limbs since 3 months, followed which history of weakness of both lower limbs since 2 months. Similar complaints in the upper limbs were noted since 1.5 months, followed by weakness of both upper limbs since 1 month, and a short duration of shortness of breath was noted since 10 days. Coming to the history of presenting illness, patient was apparently normal 3 months back. Then patient developed pains in the left lower limb to start with. Predominantly, they were in the proximal thigh region. It was more of a localized pain, non-radiating, aggravated with activity, which gradually progressed to involvement of right lower limb, proximal thigh region in the next 20 days. That was also non-radiating. And all these pains were aggravated on doing his daily activities. 1 month following lower limb pains, patient developed weakness of both lower limbs, which patient noticed in the form of history of difficulty in climbing upstairs and getting downstairs. There was more difficulty in climbing upstairs when compared to getting downstairs. And there was a history of difficulty wearing trousers, that is in the form of history of difficulty lifting his leg off the ground unsupported. And it slowly progressed to history of difficulty in getting up from squatting position. That is when he goes to the Indian toilet, he was unable to manage to get up. However, he managed to get up by taking multiple supports. History of difficulty in getting up from chair without support, and history of difficulty in getting up from supine position without support was also noted. History of difficulty in turning on bed side to side, and eventually patient became dependent and was unable to walk without support. And patient also noticed history of buckling attacks when tried to walk even with support. All these symptoms were aggravated with physical activity and had no diurnal variations. There was no history of any difficulty in gripping slippers, no history of difficulty in navigating the foot into the slippers. There was no difficulty in clearing the foot off the ground when made to walk with support, no history of difficulty in lifting the neck off the pillow or any history of head drop, no history of any stiffness or tripping attacks. There was no history of any abnormal twitching of the muscles. No history of any thinning of muscles, hypertrophy was noted in the lower limbs. No history of any positive and negative sensory symptoms like tingling, numbness, and paresthesias in both lower limbs. 15 days following onset of lower limb weakness, patient noticed pains in the left upper limb to start with, predominantly in the proximal region. Similar to the lower limb pains, it was more localized, it was non-radiating, and it slowly progressed to the left upper limb over 10 days. Patient developed weakness of both upper limbs over a span of next 15 days, which patient noted in the form of history of difficulty lifting weights above the head, history of difficulty combing his hair, history of difficulty inserting his hands into the sleeves while trying to wear a shirt. But there was no difficulty of any buttoning or unbuttoning, no history of any difficulty gripping the objects or mixing the food or bringing food to the mouth, no history of difficulty in opening the jars, no history of difficulty in holding the water when trying to wash the face, no history of any negative and positive symptomatology, sensory symptoms in upper limbs as well. And the last symptom is he had a history of shortness of breath present since 10 days, which developed during the hospital stay. It was associated with increased efforts on breathing. It was present even at rest, and it was not aggravated on lying down. Not associated with any wheeze or cough with sputum production. It was not associated with any chest pain or profuse sweating. Associated with this, he had a generalized weakness and had weight loss of around 5 kgs in the last 4 months duration. Negative history, no history of any decreased perception of smell or altered perception of smell, no history of any diminished vision or altered perception of color, no history of drooping of eyelid or double vision, no history of any decreased facial perception of sensations, no history of any difficulty chewing or moving jaw side to side, no history of any difficulty in closing the eyes, deviation of angle of mouth or drooling of saliva, or difficulty in clearing the food from the buccal cavity, no history of any diminished hearing or ringing sensation, no history of any difficulty swallowing or nasal regurgitation of the fluids, no history of any difficulty in turning head sideways and in shrugging of the shoulders, no history of difficulty in making a bolus or navigating the bolus within the oral cavity. Per se, there was no history suggestive of any cranial nerve dysfunction. No history of any, as I already mentioned, there is no positive and negative symptomatology sensory-wise. No history of any clumsiness in performing activities with upper or lower limbs. No history of any imbalance or swaying when made to walk with support. No history of any involuntary micturition, defecation, or retention of urine. No history of any resting tachycardia, abnormal sweating, erectile dysfunction, or giddiness with falls. No history of any pain abdomen, chest pain, or joint pains. No history of any abnormal behaviors or memory disturbances or speech disturbances suggesting any cognitive dysfunction. No history of any trauma, fever, loose stools, vomitings, headache, dog bite, or vaccination. He had a past history of, he's a known case of hypothyroidism and since 4 years, and he is on treatment for that. He's taking Eltroxin 100 micrograms OD. Coming to the personal history, patient is married and has 3 children. He follows a mixed diet. Bowel and bladder habits are normal and regular. Appetite and sleep were normal. He is a smoker and alcoholic. He smokes 10 BDs per day. That comes around 10 pack years. And alcohol he takes around 250 ml once a week. Family history, there were no similar complaints in the family. And drug history, there were no offending drugs. He was not taking any drugs for any kind of illness or any comorbidities. With this, I want to summarize my history. He is a 50-year-old left-handed individual, known case of hypothyroidism, presented with subacute onset, gradually progressive, asymmetric quadriparesis with proximal involvement of limbs, with query myalgias, with truncal respiratory involvement, without any neck muscle involvement, without any cranial nerve dysfunction, sensory, cerebellar, autonomic or cognitive involvement, without any family or drug history. With this, I want to come to a probable diagnosis of pure motor element syndrome, which could be secondary to myopathy, polyradicular neuropathy, or any anterior horn cell disease. I want to proceed with the examination. Coming to the general physical examination, patient is a left-handed individual. He is moderately built and nourished. He is oriented to time, place, and person. On physical examination, only grade 2 clubbing was present. Rest were normal. There were no neurocutaneous markers that were noted. Vitals, pulse rate was 76 per minute measured in the right radial artery. It was normal in character, regular in rhythm and volume. BP was 120/70 measured in the right brachial artery in supine position. Respiratory rate was found to be little higher side, that is 24 per minute. It was abdominothoracic with accessory muscles of respiration acting. And the single breath count was only 10. Temperature was 98.6 degree Fahrenheit. It was measured in the right axillary region. Coming to the higher mental function examination, patient is conscious, speech, language, memory were normal. Patient educational status, he studied up to 5th standard. MMSC was around 25. And cranial nerve examination per se revealed no abnormality. This is a cranial nerve examination in detail. It was almost normal. There were no abnormalities detected. Coming to the motor examination, on inspection, he was found to have some periscapular muscle wasting. It was noted bilaterally. It was symmetric. There were no fasciculations, no hypertrophy of the muscles noted. Attitude of the limbs, the upper limbs were found with arms abducted and elbows slightly flexed in position. Lower limbs with hip in slight flexion and knees extended and externally rotated. You can observe this bilateral periscapular wasting in this picture. And coming to the bulk of the muscle, there was no significant difference on the right and left side. The bulk was found to be almost plus or minus 1. It appeared to be symmetric on both sides. Tone was decreased in all 4 limbs. On neck muscle examination, power was found to be normal. Abdominal muscles power was weak. On upper limb examination, when examined, he was found to have that the proximal muscles were more involved when compared to the distal, with the proximal muscles having power around 2 to 3 by 5 when compared to the distal muscles having power 4 minus to 4 plus by 5. So you can see the deltoid, trapezius, supraspinatus, rhomboids, serratus anterior, all almost have 2 to 3 by 5 power, whereas distal muscles have power around 4 minus to 4 plus by 5. Thenar muscles, hypothenar muscles, lumbricals, interossei were all almost normal with slight weakness. Hand grip was normal. Coming to the lower limb power, here also it followed the same pattern. The proximal muscles were more involved. Around the hip joint, hip flexion, hip extension, hip abduction and hip adduction almost had an average power of 2 by 5, whereas the distal muscles, the knee joint and ankle joint had a power of almost 4 plus by 5. Coming to the reflexes, biceps and triceps was 2 plus, supinator and knee jerk was plus 1, whereas ankle was absent. Superficial reflexes were normal, corneal and conjunctival, jaw jerk was absent, and abdominal reflexes were present. Plantars, both were flexors. On sensory examination, fine touch and vibration were decreased below mid-calf. Vibration was found to be graded sensory loss. Other examination revealed no abnormality, it was normal. Coming to the cerebellar examination, no nystagmus, speech was normal. Coordination tests couldn't be apparently performed in view of very decreased proximal power of both upper limbs and lower limbs, and no dysdiadochokinesia. Tandem walking couldn't be done for the same reason, and gait, patient was unable to walk and he is non-ambulatory. There was no signs of any meningeal irritation. The skull and spine was normal. You can see when tried to examine for the gait, he is apparently even not able to stand and put a step forward. Other system examination, CVS per abdomen was normal. In respiratory examination, tachypnea was present. Accessory muscles of respiration were acting. Chest bilaterally symmetrical and bilateral air entry was present. However, bilateral basal creps were noted in this patient. With this, I want to summarize my examination findings. He is a 50-year-old left-handed individual, known case of hypothyroidism, presented with insidious onset, gradually progressive, asymmetric to start with, but later became symmetrical, symmetric proximal predominant LMN quadriparesis with periscapular wasting. It was associated with myalgias with truncal and respiratory involvement, without involvement of neck and bulbar muscles, with graded sensory loss below mid-calf, with retained reflexes except for the ankle jerk, without any autonomic cerebellar cognitive cranial nerve involvement, without any significant family history and drug history. With this, I would like to keep my functional diagnosis as LMN type of quadriparesis with proximal predominance with graded sensory loss. The anatomical structures I would like to consider is first being the muscle in view of retained reflexes and the predominant proximal involvement. And I also want to keep polyradiculopathy as one of the differential diagnoses in view of both sensory and motor involvement and proximal being more involved. And etiological, mostly I think it could be acquired, maybe secondary to it could be hypothyroid induced or autoimmune or paraneoplastic in view of other systemic symptoms like weight loss. On evaluation, we have sent all the routines. The complete blood picture came out to be normal. Serum electrolytes were normal. RFTs and CUV were normal. Viral screening was found to be negative. However, TSH and TPO was found to be positive. TSH was 97 milli international units per liter and TPO antibodies were found to be positive. And CKNAC was significantly elevated, 6,525 international units per liter. With the elevated TSH levels and positive anti-TPO antibodies, we considered a diagnosis of autoimmune thyroiditis with neuropathy. And so differential diagnosis of hypothyroid myopathy was considered as a primary differential diagnosis based on the lab results. However, with the significant elevation of CPK levels, it indicates significant muscle damage, which was unlikely for a sole hypothyroid myopathy. So we also considered that it could be some myositis. So we suspected myositis and sent a myositis panel. However, meanwhile, the basic investigations like NCS and EMG we want to carry out to rule out polyradiculoneuropathy. On nerve conduction studies, it was interesting that we found out patient had sensory more than motor radiculoneuropathy of bilateral lower limbs. And the amplitudes were decreased in both lower limbs more than upper limbs, and F waves were prolonged. You can see this is the motor nerve conduction studies. The amplitudes were decreased, and sensory conduction studies, the amplitudes were decreased in bilateral sural nerves, and F waves were found to be prolonged. And on electromyography, insertional activity was normal. Fibrillations 2+ was found in proximal upper limbs and lower limbs of bilaterally. MUAPs were found to be normal. Recruitment was normal or slightly reduced. There was no evidence of any early recruitment suggesting myopathy. So all these findings of NCS and EMG gave us a diagnostic dilemma that it could be some acute denervation. This is the results of EMG. So these are some of the recorded fibs and positive sharp waves in the proximal musculature of upper limbs and lower limbs. I hope the audio is audible. There is one more video of proximal musculature of lower limb showing fibrillations and positive sharp waves. And this is an interference pattern. There was no any early recruitment and it was complete interference. MUAPs were found to be normal, interestingly. And we have done other investigations like ultrasound abdomen which was found to be normal. HRCT showed an active lung infection. Ultrasound thyroid was normal. We tried to look for any paraneoplastic or occult focus of malignancy. As the patient is poor, in view of financial constraints, we couldn't do extensive workup. And in view of to rule out any autoimmune causes, we have sent serum ANA levels, dsDNA, and it was found to be normal. And PET scan was planned later if we were waiting for the myositis panel to come. Meanwhile, we got the myositis panel, which came out to be positive. SRP was 3+ positive, and Rho 52 was 2+ positive, and PMSCL 100 was 1+ positive, NXP2 was 1+ positive, and MDA5 was 1+ positive. This SRP 3+ was strongly indicating and probing to the diagnosis of immune-mediated necrotizing myositis. So we have done an extensive literature search to find out if there is any association of myopathy with neuropathy, but no evidence was found. With this, we came to the DDs of outset of autoimmune thyroiditis with polyradiculopathy from the patterns of involvement from NCS and EMG, and immune-mediated necrotizing myositis, which was evident from myositis panel. For further evaluation and confirmation of the diagnosis, we went on and further proceeded with the muscle MRI. It was done, which showed myositis in the proximal muscles of both upper limbs and lower limbs, bilateral. So you can see this is a right arm MRI showing hyperintensities in the supraspinatus, latissimus dorsi, serratus anterior, and triceps. And on the left side, it is showing hyperintensities in the deltoid, supraspinatus, and also in the triceps muscle. Bilateral thigh muscle MRI was done, which showed significant hyperintensities in the posterior compartment and also in the bilateral hamstring muscles. So all were pointing towards or probing to the diagnosis of myositis, and as confirmed from the myositis panel, it is immune-mediated necrotizing myopathy, most probably. With this, we want to treat the patient. In view of financial constraints, patient couldn't be given IVIG as patient is very poor. We have done plasmapheresis for this patient as a trial under Aarogyasri, and patient's power improved slightly from 2/5 in the proximal upper and lower limbs to 3/5, and patient was started on azathioprine 50 mg BD dosing for maintenance. I request Dr. Anusha Madam to take over the discussion. Thank you.
Thank you, Divya. I'll be sharing the discussion part. Is my screen audible? Is it visible? Sorry.
No, ma'am.
No, ma'am. It got disappear.
Okay. Is it visible?
Yes, it's visible. Please make it full screen.
Oh.
Yeah, now it's
Okay. So now we will proceed to the discussion part. So now we have diagnosed it as immune-mediated necrotizing myopathy with polyradiculoneuropathy with autoimmune thyroiditis. So coming to immune-mediated necrotizing myopathy, it's also called necrotizing autoimmune myopathy. It is a subgroup of idiopathic inflammatory myopathies. The traditional inflammatory myopathies, as we all know, like polymyositis, dermatomyositis, inclusion body myositis. This is also a subgroup of idiopathic inflammatory myopathies, which is very rare. And it has a similar clinical features as polymyositis or dermatomyositis, like proximal muscle weakness associated with myalgias, but it is separate. By specific, it has some specific histological findings, and there are some distinct clinical correlates to say that this is necrotizing autoimmune myopathies, which we'll be discussing now. So this is presence in young adulthood to older adults. It's more like 40 to 50 years of age. Females are more prone to this than males. And of this immune-mediated necrotizing myopathy, 3 major subtypes are noted. Of them, anti-SRP autoantibody immune-mediated necrotizing myopathy is a common, and the other two were anti-HMG-CoA receptor autoantibody and seronegative antibody. SRP is signal recognition particle, and this HMG-CoA receptor, what we give when we give statins, the statins go to and bind to this HMG-CoA receptor. Then autoantibodies to that receptor also produces this type of immune-mediated necrotizing myopathy. Rarely, this can be associated with myositis-associated autoantibodies like anti-mitochondrial antibodies or anti-U1 RMP antibodies or anti-synthetase antibodies. And it can also be a paraneoplastic. It can be associated with cancers. So coming to anti-SRP positive immune-mediated necrotizing myopathy. SRP is signal recognition particle. In this picture, you can see this the signal recognition particle. It helps in protein translocation of mRNA in the cell, and it helps in protein synthesis. Of all the immune-mediated necrotizing myopathy, this SRP positive, it is for 22 to 30% of all cases. And there can be a possible infectious etiology for this anti-SRP positive, and it says that there is also some immunological trigger to it. Coming to the HMG-CoA receptor antibodies, it's not that only people with history of statin use gets this myopathy. It can be present with patients who have been used statins or who have not been used statins. And duration of, if they have been used statins, the duration of its use should be at least 6 months to 3 years. And the most common statin which is used is atorvastatin, and it is associated with type 2 diabetes, and it's associated with increased susceptibility. And this is a pathomechanism of anti-HMG-CoA receptor myopathy. So when we give statin, this is a myofiber, exposure of statin results in overexpression of these HMG-CoA receptors in multiple tissues and cell types. When this HMG-CoA receptor processing occurs by antigen-presenting cells, these variants of HMG-CoA receptor or cryptic epitopes are unmasked by these drugs. And this produces some immunological trigger, and this immunological trigger causes injury to myofiber, and it causes degeneration and atrophy. Coming to the clinical features, as already Divya has mentioned, these patients present with proximal muscle weakness, which is subacute onset, involving shoulder and hip girdle muscles. Truncal weakness can also be present, and it also involves the neck. Mostly neck flexors are involved than that of neck extensors. And pharyngeal muscle involvement is also seen, the prominent oropharyngeal muscle dysphasia, and they may have nasal speech and voice hoarseness. Mild facial muscle weakness can also be seen, and they have diffuse myalgias. If they have dyspnea, it is secondary to diaphragmatic muscle involvement. And it's associated with autoimmune diseases. So like sometimes the connective tissue disease features like arthralgia, Raynaud phenomenon can also be present in these patients. And as there are connective tissue associated with connective tissue disorder, ILD can be present in 50% of the patients. And the cardiac involvement, it is manifested with myocarditis, pericarditis, systolic heart failure, conduction blocks, and cutaneous features. Normally, this dermatomyositis has this heliotrope rash, Guthrun's papules, shawl type rash, and it can be seen with this immune-mediated necrotizing myopathy of this HMG-CoA receptor antibody type. To the diagnostic approach, how we will diagnose this disease? The labs involving complete blood count with differential should be done, and the serum creatine kinase, it is raised in immune-mediated necrotizing myopathy. To say it should be more than 1,000 international units. And ESR, CRP, mostly they are normal or mildly elevated. If they are elevated in this immune-mediated necrotizing myopathy, it says that there is some infection or associated cancer or associated autoimmune disease with the patient. And TSH, to rule out some endocrine myopathies, we do it. And HIV, HBsAg, HCV, these should be done to rule out viral myositis. And also we have to done it prior because we will give this immunosuppressants for these patients so that these don't reactivate. And myositis specific and autoantibodies, this is a very important test which helps in diagnosis. And depending upon this test, depending upon which antibody is positive, the treatment also changes. Sometimes when this myocytic specific antibodies is negative, but all the clinical features, creatine kinase is elevated, and the clinical features are suggestive of some myositis, then myositis associated autoantibodies should be done. Like these includes anti-mitochondrial antibodies, anti-UNRNTs, anti-Rho antibodies. And coming to the testing for myopathies, electromyography should be done. These EMG findings include slightly increased insertional activity with positive sharp waves or FIPS in spontaneous, and small myopathic MUAPs, which are polyphasic in MUAP testing, and early recruitment with complete interference pattern in this EMG. When we come to skeletal muscle imaging, proximal muscles are more involved. We have to do T1 with stir images, where this T1 images shows if there is any atrophy of the muscles with fatty replacement, which they include hyperintensities. And in stir images show if there is inflammation, there will be edema in the muscles, which can be hyperintense in stir images. Muscle biopsy is not needed for each and every patient. It is done only in selected patients where the tests are equivocal. If this myositis panel is negative or EMG findings are not suggestive of this myopathies, if skeletal muscle imaging, which we do, is not concluding of this myositis. So it is done only in those selected patients when the disease which is not it is inconclusive. Into the skeletal muscle imaging, what I already said, mostly in this immune-mediated necrotizing myopathy, the paraspinals, gluteals, and posterior and medial compartments of thigh are more commonly involved. And there is generalized muscle edema seen as hyperintensity in stir images, and fatty infiltration, which is seen with T1 hyperintensity with minimal facial edema. So this is a thigh MRI with muscle edema. We can see this is the anterior compartment, posterior compartment. This is seen mostly in the posterior compartment, like semimembranosus, semitendinosus muscles. And few have this rectus femoris is also inflamed. So this we can see in stir images and T1 images. The muscle biopsy. Muscle biopsy is diagnostic and it is conclusive when the other investigations are unequivocal. So the most important characteristic of immune-mediated necrotizing myopathy is quasi-inflammatory. Normally, these traditional myositis have more of inflammatory infiltrate. Dermatomyositis has a signature like perifascicular atrophy. This is a perifascicular atrophy of muscle fibers. But in immune-mediated necrotizing myopathy, the inflammatory cells are very less. But we can see more of myonecrosis and myophagocytosis. So when we suspect immune-mediated necrotizing myopathy, first we have to see for creatine kinase and see for proximal muscle weakness and absence of any cutaneous features, which is suggestive of dermatomyositis. And ask for statin use. If there is statin use and or any other myotoxic agent which causes CK elevation, we ask them to stop the drug. And then if the patient has improved, no further workup is necessary. If there is no history of statin use, then I have to obtain the myositis panel, EMG and MRI. If it's positive for myositis panel, we have to conclude it as immune-mediated necrotizing myopathy, depending upon which antibody has become positive. If those tests are negative, then the diagnosis is unlikely. If these antibodies are negative, then we can conclude it as seronegative autoantibody immune-mediated necrotizing myopathy pending the muscle biopsy results. And we have to obtain the muscle biopsy result. If these antibodies are positive, no need to do a muscle biopsy and we can go straight ahead with the treatment. Coming to the diagnostic criteria of immune-mediated necrotizing myopathy. Clinical criteria includes inclusion criteria and exclusion criteria. Age should be more than 18 years, which is subacute or insidious in onset, associated with symmetric proximal muscle weakness and next flexor weakness. And the exclusion, it should be clinical features of inclusion body myositis should be absent, which includes the proximal lower limbs like quadriceps weakness and upper limb, in the upper limb, flexor muscle, forearm flexors are involved in inclusion body myositis. There should not be any weakness of ocular weakness or isolated dysarthria, neck extensor weakness, to see some of the dystrophies like oculopharyngeomuscular dystrophies. And there should not be any history of toxin intake to rule out a toxic myopathy or endocrinopathy, amyloidosis, or SMS. CK should be normally more than 1000 international units. And in the laboratory criteria, the positive EMGs, which is suggestive of fibrillation potentials, positive sharp waves, and MUAPs or short duration, small amplitude MUAPs. If muscle MRI, there should be increased signal within the muscle stir images. That shows there is an active inflammation of the muscle. And myositis specific autoantibodies are detected in the serum. And the muscle biopsy suggestive of muscle fiber necrosis with very sparse inflammatory infiltrate. This is the signature of immune-mediated necrotizing myopathy. Coming to the treatment. But the goals of the therapy. Goals of the therapy is first to achieve the long-standing remission. And we have to decrease the muscle weakness and increase the endurance of the muscle. And we have to minimize the atrophy and improve the functional ability of the patient. When it is severe disease, immunosuppressive treatment should be given with combination of glucocorticoids and IVIG, or rituximab can be given. But if the disease is refractory, then there are also few studies which have reported that plasma exchange is also effective in this SRP positive autoantibody related immune-mediated necrotizing myopathy. If it's very severe disease, then we can add azathioprine or MMF or methotrexate to the regimen. And these glucocorticoids which we have started should be tapered to the minimum possible dose, and the tapering should be done within 3 to 6 months. So these are the few case series reports where they have given plasma exchange therapy in refractory inflammatory myopathy with anti-SRP positive anti-autoantibodies. They have concluded that it is effective in refractory IIM patients who have positive SRP autoantibodies. When the disease is not so severe, we can start with oral glucocorticoids with methotrexate. If methotrexate is contraindicated, then we can substitute with azathioprine or MMF. And how do you monitor the treatment response? Normally, when we taper off the glucocorticoids, the disease often flares up. This immunosuppression treatment should be given for at least 1 to 2 years. And we have to do a serial assessments during follow-up of muscle strength and endurance. And every time when the patient follows up, these blood tests should be repeated like creatine kinase, CBC, LFT, and RFT to see if there is any further inflammation and also to see the drug adverse effects. The target of creatine kinase should be less than 1000 international units per deciliter. And we can also do an MRI to see if there is any persistent edema. If there is persistent edema, then we have to go for aggressive therapy. If there is no persistent edema, if there is already fat has been replaced with atrophy in it, then it does not mandate any further aggressive therapy. And physical exercise should be suggested. It helps in aerobic metabolism and decreases the muscle atrophy. And what are the guidelines for relapse or refractory disease? A relapse is the recurrence of the symptom of active disease once it has been it is under remission. It is diagnosed with elevated creatine kinase again, and the treatment is we have to again start with induction therapy with IV immunoglobulins or rituximab. The disease is said to be refractory if there is persistent weakness and there is no remission. Elevated CK is also persisting despite the immunosuppressive therapy. Then we can give aggressive treatment, and again the other drugs like tacrolimus or plasma exchange can be tried with refractory disease. These are my references. Thank you.
Thank you, Dr. Divya and Dr. Anusha, for nice illustration and discussion of the case. But why this case is so perplexing in a sense, like what is diagnosis, first point. So it looks clear-cut LMN motor syndrome, but what made complicated in diagnosis, one thing is to start with asymmetrical, then progression and reach the proximal predominant, more of a symmetrical fashion, the ending fashion. So the first possibility with retained reflexes, and second possibility, with the other findings of periscapular fasciculations and wasting, one feature. So to summarize the diagnosis, the one point is first possibility is myopathy, always is considered, because one thing is asymmetrical almost myopathy with myalgias is one characteristic feature, which made to think of something we're dealing with more of myopathy, because the pains are localized, not at radiating. That's one point. Coming to radiculopathy, what we consider is because still patient has some sort of asymmetrical fashion and examination. It is not like a graded sensory loss, which is again featured against to the radiculoneuropathy. And then other thing we consider is like an anti-Honsel. History, of course, patient didn't give any history of any muscle wasting, but on examination we surprisingly found the periscapular wasting without vesiculation. But retained reflexes is again a feature. Coming to the muscle condition producing to the extent of periscapular wasting in a span of 2-3 months, little unlikely. Again, radiculopathy producing wasting in a span of 2-3 months, still unlikely. Of course, to consider anti-Honsel, there are still possibilities, but against points, still retained reflexes and associated myalgias. So, to adding to this confusion, ENMD is still more adding complexity to the case, more of sensory involvement and absence of F phase and more of decreased amplitude. And EMG again more suggestive of acute denervation pattern. So something we are dealing with not a clear-cut myopathy, a myopathy with some sort of polyradicular neuropathy picture. So different neuraxis involved, and in a span of 3 months period, with systemic, not so significant systemic symptoms except some muscle weight loss. So we thought some systemic disease which is affecting both muscle and sort of radicular neuropathy picture. Of course, he's an alcoholic. That also should be considered, but producing extent of this much of muscle weakness with radical neuropathy picture in ENMG is unlikely. So to add all these complications, we thought something like some systemic disease which is affecting the both muscle and radical neuropathy. So what is the picture which we consider based upon history is one thing is white class, and surprisingly our labs most suggestive of autoimmune thyroiditis. That's one picture. So apart from autoimmune character, what we can think of is paraneoplastic. Paraneoplastic, of course, except white class, nothing is so contributory for this patient. So perplexing diagnosis in future of axis neuraxis involvement and progression of disease, adding electrophysiological diagnosis. Then coming to the evolution of the disease, you say, for example, patient most of the times hypothyroidic myopathy, we don't see to the extent of involvement of respiratory distress, patient require plasma exchange, intercostal muscle weakness. This is not possible in just 2-3 months. We see most of acquired hypothyroidic myopathy. So something we're dealing with not only hypothyroid myopathy, something more complicated etiology we can think of. Then we thought, I think surprisingly, then we thought it is not a simple hypothyroidic myopathy, not just because of increased CPK, and which is also again not in the range of hypothyroidic myopathy. Then we thought something myositis panel, which is actually positive in this case, especially pure positive. Then same time we tried to look for the paraneoplastic. Paraneoplastic, we didn't go much of PET scan. Relatively, the screening of thyroid and chest and the CT chest and abdominal were relatively normal. So then we thought something we're dealing with more like a complex, most very devastating muscle pathology, which is systemic one, mostly into autoimmune necrotizing myopathy was the diagnosis one. Then outcome say why it is so perplexed means in a span of 3 months, it was actually patient was admitted for the last 4 weeks in our department. Patient almost came with just myalgias and weakness. He was just walking with support and all. Now, with despite so much of diagnosis going on, the evaluation is going on. Patient is started on steroids. Patient put on plasma paresis. Is not completely symptom free. We can call there is slight increase in muscle weakness. Nothing but patient still intermittently still now require oxygen support and all. So such a outcome wise also something more complex wise and all. So that's why one thing, the concluding points which practically once I said is when you deal with patient with the diagnosis both muscle and another neuraxis involvement as radiculoneuropathy, there is systemic acquired etiology is going on, and simple hypothyroid myopathies will not produce some necrotizing myopathy characters, or because we see a lot of polymyositis will not happen in just 2-3 months to the state of respiratory distress. That's one point. The two acquired in starting illness 2-3 months. So something more severe pathology is operating. That's one point we should think whenever dealing with proximal muscle myalgias with weakness, don't think simple myositis or simple like a inflammatory myositis. Something apart from inflammatory myositis, something necrotizing character coming to the picture, which is classically positive in this case and all. So aggressive treatment, not mostly with immunosuppressants. Actually, we started steroids followed by plasma exchange, and plasma exchange is also still described in case of few cases of this positive cases and all. But we should try for IVAZ also. Financially, we are still concerned, but the patient is still, we are hoping to go for next therapy of IVAZ and all. So the concluding remarks here, whenever it comes to proximal weakness, myelitis, don't jump into the myositis and go to treatment. Think something, the evaluation also give clue, and how the patient response also guides the treatment, and that gives a clinching mass to the diagnosis, evaluation, and outcome. So thanks to our team who made a really good diagnosis and followed the case. Almost we did all our efforts to save the patient to go into the respiratory distress into the ventilator. So timely involvement of immunosuppressions in the form of steroids and plasma exchanges was done.
Thank you. Thank you, Dr. Sampath, for a wonderful case. And as you all know, that the algorithm which Dr. Shah presented on the approach to the immune-mediated necrotizing myositis is fantastic, and I am sure that the students all would have been benefited by the classic approach and when to suspect. As Professor Sampath said, you should have a high index of suspicion, otherwise you will miss the diagnosis. Secondly, in this case, as you see, the another important, very important thing is the use of musculoskeletal MRI. The slide which showed beautifully the various muscles and how the hyperintensity in the still images of the muscle. It now, the still images of the muscle is another important tool for neurologists which is being underused. And now you start to using the musculoskeletal MRI more and more, and this whole body still is one of the very, very good method of finding out neurocysticercus also. And unknown locations, undisclosed locations, you want to suspect. When you have one cyst in the brain, you want to see the screening. Do a whole body still for the musculoskeletal still images of the body. You will see. You can even look at the net. Classical still images showing scattered neurocysticercus, you'll be able to find out. So that is another, and another important take-home point, which impressive take-home point, which Dr. Sampath Kumar said. When you have a mixture of both neurogenic and myogenic pattern together, this should ring a bell in you that you are dealing something unique, either an inflammatory myopathy or an immune-mediated myopathy. When you have features in the EMG suggestive of neurogenic pattern and mixture of neurogenic and myogenic pattern when it comes to you, that should be one of the very, very important thing that you should strongly suspect inflammatory myopathy. Even in inclusion body myositis, a similar picture you'll be able to see electrophysiologically. So, as a whole, I'm grateful to the excellent presentation from the Nellore. And there is any questions from the chat box? There's no open questions. Anybody wants any comments? And sir, Professor Sudhisha is there online?
Sir, actually there is some
Emergency.
connection problem, so he's not there.
I sincerely thank Dr. Anusha, Dr. Divya, and the Sampath for a wonderful presentation. I hand over to.
Thank you, sir.
Thank you.
Thank you. Thank you, sir.
Thank you,
And,
sir. Nice moderation and give the valuable concluding remarks also to the case. Thank you, sir.
Thank you, sir.
Thank you.
Thank you,
Sir, today we are incredibly grateful to all of you for joining us in the Secret of Neurology, and we are successfully completing the 57th session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President of Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 57 months. A special thanks to you goes to our esteemed course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology. This program will undoubtedly a very valuable resource for all the DM and DNB students. And we are incredibly grateful to the young neurologist, Dr. Divya, for sharing their insightful case
Thank you.
presentation. And we are very thankful to Dr. Anusha for localization this case. And we are grateful and thankful to Dr. Sampath Sir, Professor and HOD in Department of Neurology, Narayana Medical College, Nellore, for giving insight of this case and providing the crucial learning points and summarizing the proceeding of the unique presentation. Once again, a heartfelt thank you to all of you for your gracious presence and to being with us in this 57th session of Secret of Neurology. We are eagerly waiting for you for the next session in the month of May. So till then, stay safe and take care. And thank you to all of you. Thank you, sir.
Thank you.
Thank you.
Thank you,
Thank you,
thank
sir.
you.
Thank you. Thank you.
Thank you, ma'am.